Dr. Sanjeev Singh, sir, and as sir doesn't require any formal introduction as such, but it's been an honor for me to introduce him any which ways. He would be taking up the session about the medical legal implications of MR, the legal aspects, confidentiality, security, and safety, etc. And sir, as we all know, is the medical director of AIIMS Faridabad and chief medical superintendent of AIIMS Kochi. Pediatrician by training, has worked as a regional coordinator at WHO India in a disease eradication program before joining Amrita Institute of Medical Sciences. He is an improvement advisor at the Institute of Healthcare Improvement, IHI, in the US. He's also an ambassador from India to Society of Healthcare Epidemiology of America and has been adjudged as hero of infection control by Association of Professionals of Infection Control, US. He's the international surveyor of ISQA. He is responsible for drafting the accreditation standards for the third and fourth edition at NABH and presently vice chairman of the research committee at NABH. He's the chairman of the technical committee at HPI and Healthcare Sector Council of India, that's GOI. He is member of the Drug Safety Council and member of the Indian National Advisory Body on Occupational Exposures. He is also the member of Healthcare Committee at Federation of Indian Chamber of Commerce of India, FICCI, and Secretary of AHPI Delhi NCR. He is an external consultant to WHO on regulatory licensing policy issues and the quality interventions in India. He is a technical advisor to several state government healthcare projects such as e-learning, reduction of IMR, antibiotic stewardship and infection control, and also the technical expert for University of Antwerp's Point Prevalence, Surveillance and Institute of Healthcare Improvement, USA, on neonatal collaborative program. So with much ado, it's over to Dr. Sanjeev Kumar, sir, for the next session. Over to you, sir.
Thank you, Devasri. So good to see you.
Good to see you, sir.
So thanks, Dr. Patil. Dr. Patil has been my teacher. He has been my guide. When I was stepping into hospital management scenario, and he has been the phenomenal support. I didn't realize there are so many people who have come together for organizing this. So there is CAHO, there is ASCOA, there is Bombay Hospital, and there is HERA India. So thank you all for giving this opportunity. And I know every organization becomes very tough, but with the support of Bombay Hospital, I think this would have been a cakewalk. So I'll quickly go through what I've been asked to take. It's the medical legal implications. And what I'm going to cover is the documentation, some of the legal implementations, and I'll summarize. So what exactly, there was a fantastic presentation just ahead of me, where most of it was sort of covered, that there is a clinical documentation. So what we need to realize that most of the documentation which would be there at part of the medical record, whether it is history and physical examination, whether it's past history, family, either it is reassessments, it is progress, it is operation theater notes, it's nursing, if it is TPR, all of it is having a legal implications, and that is where this document becomes extremely important. So what is, this document is important for who, and what is the benefit, and who all needs to participate. So basically, the clinical team, they are registered medical practitioners. They do this documentation, and based on their expertise, knowledge, and skills, they need to do that. Nursing is another group of people who are again registered medical staff. Midwifery are other group of people who are there. Then there are clinical pharmacists who are again registered people who need to document. Plus there are now the support services who are part of the multidisciplinary team, and they need to be part of this whole documentation process. And then it needs to have it's a communication flow, and generally it is done in a chronological manner. So what gets into a medical record is basically a complete information of a patient end to end, when he had actually been seen in the outpatient departments, all of his diagnostics, and a follow-up of these patients at every level. When do you document? Is every event for this patient care wherever you are, either revising, changing, reassessing, redesigning, recalibrating the treatment at every point of time. There needs to be a documentation process. So why it needs to be done? Because it's legal in nature, and this is in the court of law, just in case, though I also would say that 99.9% of these documentations don't go into the court of law, but it is good clinical practice also to document, so that if you need to do a clinical audit, if you need to do a nursing audit, if you do need to do a prescription audit, if you need to do a quality improvement initiative, this comes in very handy if retrospectively it is all sort of documented well. How it needs to be done, it was covered in the previous section very, very well. So there are various levels of documentation. I'm not talking about the medical records, but there are these quality management system which says that Apex manual is the highest degree of documentation. But what I'm coming to is this point number 4, where the records, medical records, formats, registers, and forms comes in. So this is again very critical for any level of documentation. It's just not for accreditation standard, but for any evaluation of the work which gets done through the standard operating protocol. Now, if you have an electronic health record system, which many hospitals are opting for, and it's just not for billing, but for clinical services, standardization of these EHR or live health records are extremely critical. And how does that, because they need to talk to each other, and HL7 digital and communication, ICD-10 classification, HIPAA compliance are some of the basic standardization practices which needs to be followed if our medical records is into EHR form. And IT 2000 Act allows electronic medical records being presented in the court of law. So if you quickly look at what would be NABH requirement, they have a chapter 10, and there is a control of data and information, which is important. So what they are looking at is the processes standardization, they are looking at analysis, they're looking at dissemination of this information, and that is what medical record is all about. They're also looking at, can we retrieve this information whenever it is required, so the patients can have multiple revisits, and is it possible to get it done? And the clinical and managerial staff, all those who are registered and those who are support services as a multidisciplinary care, are they documenting? Next important point, as was also covered in the previous lecture, was completeness and accuracy. So unique identifier is important, the content is important, and this is where the standard operating protocol for each institution would come in. The medical records that provide should be up to date chronologically. The authorized signatory should be there. SNDT is what was discussed. Author of entry should be identifiable. There should not be any abbreviations and things like that. Why we need to, I am rushing it because this was already covered in the session before me. The medical records is important for continuity of care. So when the patient gets in, he has a face sheet and he has an admission and a general consent has been taken, but then the course of the treatment can all be reflective if there is a case sheet. So basically the reason for admission is critical, because many a times we see that there is a history and physical examination being taken, but the differential diagnosis is missing and the care plan gets missed. So assessment and reassessment again is extremely important, and that's the key for good medical record keeping. Plus all the investigations which has been done, which should be sort of part of continuity of the care, and any of the procedures which has been performed on the patient. So all this till the patient gets discharged or there is a death, all this would formulate a part of good medical record, and this is important because it has a legal implication. So whenever there is a court of law and there is a case which gets come in, there is always an expert which has been called who looks at the documentation and then would call for a particular judgment. Now, what would be the case scenario? So this is a history and physical examination where the doctor who has seen the date and the time and the important information of history and physical illness, present illness, and the on examination is written. Plus, if there are plan of care, and it is about differential diagnosis, it is about formulation of an impression. So it cannot be about just a surgical procedure or any single liner, but it is important. How do you reach to that information? So it could be an end-stage renal disease, it could be on the maintenance dialysis, it could be on diabetic nephropathy, it could be chronic myoclonic fasciitis. So all this is a differential diagnosis. Based on that, you decide on the goals of care. So it could be on the patient could be just kept because of his biochemical and microbiological molecular parameters or imaging parameters. You decide to keep him on a particular procedure. Now, reassessments are also critical, and this is how, when the date and time and what exactly was particularly done for that patient and what is the plan for the day, plan for the next day is important. And whenever anybody, the author of entry has to be identified, and that is where it is critical, and it is extremely important. So every time the case is seen, you have a reevaluation. If you are changing a plan because of any deterioration or improvement of the clinical features, that is all recorded. Now, if you just write any of the information without understanding that the seen by a doctor, date and time is missing, that is one of the most critical information which is missing, and it may again legally go wrong, because it may look like post facto you have filled in that information and we have actually no proof of who has seen this. Many times we see a page like this which exists in the medical records, but there is absolutely nothing written. So these are all makes you legally uncompliant, and in the court of law you will not be able to save. So vulnerability, restraint, nutritional, rehabilitation, plan of care, if there is no information, even if it is sketchy or no information, it is something which is extremely risky. So some of the interesting features with the medical records are something like this, where you become uncompliant, it is unwarranted, and it is irrational to practice like this. So legibility is one, because whatever you write, it needs to be sort of adhered to, it needs to be compliant, then the nurse should know it, the clinical pharmacist should know it, then the junior resident, the senior resident should know it. But if it's not written properly, it will be difficult. In the case, in the reassessment, if like I was doing an assessment and there was a, in one of the hospitals, day one, the patient has done well. Second day, the patient slept well, passed stool and is stable. Third day, patient slept well, passed stool and is stable. Fourth day, patient slept well, passed stool and is stable. If he's passing stool, if he's stable, and if he's sleeping well, why the hell he is in the hospital? Similarly, here for the last 8 days, the patient is stable, but he's still there in the hospital. So somewhere something has gone wrong, and this is where it is good to sort of internally evaluate and audit. We make a mess because we have actually no clarity of what we need to prescribe. We write a lot of, and these are all medical legal implications, because then the physician orders and the progress sheet is sort of, it is colluding in nature, and it doesn't give a compelling information which is important for a nurse to pick and choose, send in investigations and write. So we tend to always do that. Another mistake which is generally done is to not write drug charts separately, but write 1 to 2. I was also doing an assessment of another hospital where there was an anesthetist whose mother was admitted, and injection adrenomycin was given. And injection adrenomycin was given on day 1. It was mentioned as repeat all, and injection adrenomycin was given on day 2. It was written as repeat all, and injection adrenomycin was given on day 3. And day 4 is where this anesthetist, when he looked at this fluid, and he's seeing every day it's been given, where it is extremely risky. And then there is where he alerted, adrenomycin is given on day 1 and day 28. Just because of repeat all, it was given. And then there was a very visible cardiotoxicity, which was there and evaluated. So similarly, we do this mistake, and it is again leads to your being legally non-compliant. We write many things. You have written repeat 1. We have no idea about repeat 2, because we don't know whether 2 has been cancelled. Who has cancelled this? You have written 3, but now where is 4 and who has cancelled? What drug was there on 4 which got cancelled? So that information is lacking, and that is where it becomes very risky. What it needs to be done is something like this, where physician orders and progress sheets are written extremely carefully, and there is the date, there is a time, there is a drug, there is a dose, there is a frequency, there is a duration, and based on some of the biochemical parameters, it is continued. So the support group should also make that recommendation. The physiotherapist should recommend because that is a therapy. The clinical pharmacist should recommend because it's a therapy. The dietitian should make medical records because that's a therapy. Medical social workers doing psychosocial financial information should record because that's a therapy again. We do lots of time verbal order that also needs to be read back and documented. Referrals at all point should be documented legally. It is important. Informed consent is the most important information from legal point of view, and try and cover that in subsequent slides. There is surrogate consent because just in case an immediate cut and kin is not there, as a standard operating protocol, surrogate consent can also give a consent, and in case of emergency, the physicians can give a consent. Discharge summary must have been covered. We also see these words always being used, DNR and end of life care. So Supreme Court has recently come out with a fantastic guideline. Earlier, because of the Aruna Shanbas case, there was a very bulky information of passive euthanasia versus active euthanasia, and it was a very lengthy and a circuitous process. But now they talk about formulating a bioethics committee within the institution with 1 person or 2 person representing from the civil society, and they can take a judgment on withdrawal and withholding of information. Sorry,
Sir, sorry to intervene. We are running out of time. Can hasten.
Okay. Yeah, I'll do that.
Thank you, sir.
Medico-legally, no death certificate should be given in these cases if it is brought death, if there is a death during examination, death after admission, and a natural death, and during anesthetics process. Medico-legally, if there is a process which needs to be covered, and the medical records should be appropriately filled, which includes accident and wound certification. There's a confidentiality of the patient information, which is critical. So these are some of the acts which are important, which needs appropriate medico-legal. Retention of the files in the OP is mentioned as per the MOCRA Act, OP 3 years, IP 5 years, and some of the states is 10 years, and medico-legal lifelong. National Medical Commission Act 2019 says a registered medical practitioners can only document, and if it is not done, there is a fine and implication. So the documentation is very critical. There's a Registration of Births and Deaths Act, which also says that it needs to be done within 7 days and 21 days. If it's not done, non-compliance has a penalty, and the medical record submission is again important. The Narcotic and Psychotropic Act, there is a triplicate form, which is, there has to be a prescription, there is a triplicate form which has to be submitted, and that also requires medical records documentation, which is again critical. And it needs to be done in this manner. Consumer Protection Act demands an adequate medical documentation in the court of law, whether it is in the state or district. Pharmacy Act defines how the content of the prescription should be there, and that is again part of the medical records documentation, and both in outpatient and inpatient, and that non-compliance again has a penalty. Drugs and Cosmetic Act again has a way it needs to be documented, which is again defined both in the blood bank and in the pharmacy area, and then if non-compliance has a penalty. PNDT has a documentation, whether it is Form F and Form G, that consent and adequate information should be there, and that should be recorded, submitted at appropriate time. Important drugs and other things are again very critical. For Transplant Human and Organ Act, the medical record documentation again is very critical, plus the recording, which is not part of the today's session. MTP, I'll end with just 2-3 slides. MTP, the confidentiality to be maintained and as part of the medical records, and if it is not done, there is a non-compliance penalty, and that is where again medical records is important. So to end, the department, anybody can access a medical record. That needs to be done by health authorities. It is permissible by police authorities, permissible by courts, tribunal, consumer laws, permissible, and any affiliated institutions is permissible. And there is a Right to Information Act, and based on that, there is information which needs to be provided. It applies for the government hospitals, and it's a quasi-government, but may not be applicable completely in a private institution. So thank you so much, Dr. Patil and the CAHO team, for giving this opportunity, and back to you.
Yeah, thank you so much, sir, for such an informative and wonderful session, sir. So many case study and examples which clear all the doubts. But 2-3 questions we have, sir, in Q&A box. So should I ask, sir?
Yeah.
Yeah. First question is, can the patient be given his or her original records, patient records?
So under National Medical Commission Act or Medical Council of India Act 1946, within 72 hours, if the patient is demanding or patient has authorized with his signature, then the surrogate group of people can collect medical records. The medical records always belongs to the patient. This understanding that it belongs to the hospital is wrong. Hospital is not the custodian. It is only a storage area. Otherwise, it is his or her information belongs to them. Whenever they demand it, it needs to be supplied, and the time given is 72 hours.
Okay, thank you so much, sir. Another question, doctor, if doctor write in death certificate for the patient that only cardiac arrest and brain death is mentioned in that particular death certificate, and actual death happened due to the infection and then death happened. So here the doctor didn't mention in the death certificate, only the mode of the death was written by the doctor. So what medical legal implication could be there to the doctor, sir?
So under Brain and Death Act, cardiorespiratory arrest, cardiac arrest, respiratory arrest is not the cause of death. And this has been trained, this training has been given at all medical colleges, 647 medical colleges in the country for all undergraduate and postgraduate students. This is only an event and not the cause. And cause should also always be written, which is antecedent cause and an immediate cause, according to the WHO format which has been given for the death. Cardiac arrest, respiratory arrest, cardiorespiratory arrest is never a cause of death.
Okay, thank you so much, sir. Sir, one more small question. What should be the retention policy of medical record regarding non-MLC death files and pediatric patients? It is little different topic, but one question has raised, sir, in this. If you can clarify.
So if it is outpatient, it is 3 years, and inpatients maximum 10 years.